Yeah. Yep.
I see green dot.
All right.
Mic is on.
All right. My mic is on. Well, I do apologize. My voice is gone, and we're trying to work out the subtitles, but I'll do the best I can. Um, for those of you who don't know, I don't normally sound like this. Uh, and my name is John Phillips. My brother did talk before me, so I guess it's kind of a spoiler alert. We are both residents here in Joplin. Today, I'm going to, and again, I apologize. This sounds painful to me hearing my own voice. I'm going to go through a lecture, kind of a broad topic on overdoses, particularly common overdoses. And I do want to start off by just saying I am very appreciative for what you guys do for our community and all the excellent work that you guys do on a daily basis. And we have a privilege and an honor to take a little bit of y'all's time every year. And we're always glad when we get the opportunity. So we are very thankful for that. A little about myself. Apparently, I grew up in the Ozarks, the rural Missouri Ozarks, about 3 hours east of here. So this is more or less home for me. I went to school after about 18. I went to the big city of Springfield, and I went and got a bachelor's degree, and later went on to get a master's and a doctorate because I'm a glutton for punishment. And was fortunate enough to get to move back to Southwest Missouri to pursue residency in emergency medicine here in Joplin. So, and there's that fact about me and my brother. We are twin brothers. We just aren't each other's twins. It's a riddle, and if you guys can figure it out, there's a secret prize that I will think of later. I'm pretty sure there's no financial disclosures. uh, Moving on. So, learning objectives for this. When I think about this topic, my goal today is not necessarily to go through every intervention in terms of the exact dose of a medication or the exact toxic dose of a substance. What I really want to do is to try to reinforce and provide thoughts that are a framework for assessing patients in pre-hospital care and utilizing those frameworks that hopefully are of a bias and certainly things that I've seen and observed in the field myself. So creating that framework is the big idea. There'll be some nuanced things that I'll sprinkle in here and there, but that's the big thing. So starting off kind of looking at understanding the importance of recognizing overdose symptoms. And there's a lot that goes into that. Common substances involved in overdose, that's an ever-moving target. I got a notification today from the Missouri Department of Health, not unique to me. I think it went out to a lot of people about some new things that we've seen. This becoming more of an issue, synthetic medications that are available that cause common drugs of abuse and overdose symptoms. So it's a moving target. Wanting also to be able to look at management strategies, connecting the clinical presentation to some degree, but not necessarily getting too far into the woods on that. And there's some public health implications. That was who actually sent out the message today. And then lastly, if we have time, we can go through some clinical practice cases. If my voice holds out, and I am confident that I will squeak and squall all the way. All right, overview of overdoses. You got kind of two big categories of things I look at it, and this is kind of what hopefully we'll touch on in each one of these particular substances. Is the epidemiology to some degree. Last time I did this, I put a lot more statistics in it, and I know how everybody loves numbers and statistics. So I got rid of most of that, and I put in some basic stuff because I'm kind of basic, and I like to think of things in as most boiled down as possible. But there's some numbers that are interesting. The demographics, aren't super duper necessarily important, but it is something to be considered. And then there is some trends. Pathophysiology. I do love pathophysiology, but we won't get too far in the weeds. I say that, and I'll probably ramble about some. But how overdoses occur and why does that matter? And back to the signs and symptoms and how they can connect these. And there's some things like we all love toxidromes that all sometimes look like the same thing. So initial approach to management is also something I'll tag in there. These are the numbers, some numbers that are by the CDC that are kind of incomplete in terms of the total numbers because they're not all states that report. Um, what it shows is overall deaths. These are death summaries. One of the reporting databases that talks about, particularly through what they would call a drug overdose. So these numbers are a little bit higher than last year's numbers. Actually, this is 2023. Last year was 2022 when I had the numbers. I think it was 51,000. Again, not all states, particularly large states. I believe it's like California, Texas, and Florida, which all have large populations. I don't think are necessarily included in this data. So a lot of people are affected by this. And one thing I find interesting is that when you have an overdose with these statistics, it says, somewhere around less than 70%, but close to 70% of people had an opportunity for an intervention. I don't know exactly how they define that, but there is opportunity to potentially provide reversal agents, to provide supportive care, to do the things that you guys do so very well. Just big numbers, a lot of things, the buzzy stuff, opioids, and are highly involved synthetic and illegally made fentanyls are obviously involved. I had a lady with a fentanyl patch on her foot yesterday in the emergency department. I don't know how it got there. She didn't know how it got there. And I really don't either, but it did knock her blood pressure down. She made it out okay. So those things are something we see on a daily basis, and either they're primary sources, a lot of these of the drug overdose that we see, or connected to it, if not the primary. Co-ingestion is a big thing. So in Missouri, the numbers are a little bit different. These are actually discordant, but it's around 1,900 essentially. It was down, I think, the last year's data that they had shown, the CDC numbers. It was around 2,200 deaths. This is, again, I say last year was last year that I could find reported. The databases have changed a little bit, so it says we're trending downward. Again, the opportunity for intervention is a big key, or something I find to be important, because that's where we come in theory. So a good portion of folks, over 70%, had an opportunity for at least some sort of intervention. And this is, again, patients that had, or people that had died. Opioid stimulants and our favorite methamphetamine are many times the chief drugs of abuse that we see. All right, so just kind of not going to go too much into this, but thinking about physiology, pathophysiology in broad strokes. And maybe one step back when I have this first kind of thing we're talking about, an overdose can be accidental or intentional. Accidental could be the 5-year-old kid who gets grandma's beta blocker, or it could be the patient or the person who's abusing the drug that just accidentally over ingests. And then we have folks that may self-harm. So accidental or intentional. My now 14-year-old daughter decided to take some of her grandmother's, or allegedly take some of her grandmother's beta blocker. This is many years ago. I think it was going to be a date night. Instead, we went to Cox South and talked to Poison Control and hung out for a while. So things like that can happen. So it involves over-the-counter medication, street drugs, unintentional interactions between medications. Seldomly, we get bits and pieces of information in the ER, and you guys do even better work with less information, like an exhaustive list of patients' drugs. Some people are on Nana's got 5 different medications that suppress her breathing. Nana's got 5 different medications that can cause her to be agitated. So these all get mixed together. So interactions are important, and in co-ingestion situations, certainly important. Physiologic. The physiology, basically, it breaks down to various toxins will exceed the body's mechanistic ability to filter it out. Some directly attack the enzymatic structures. They're harmful. Some just, when taken in large doses, your body is unable to process and handle it. So the toxins build up, and then we start seeing the secondary effects. Those effects can be seen on the organ systems. So neuro, altered mental status, vomiting, nauseated, respiratory suppression, so pulmonary. And these can have, again, synergistic effects when added together. All right, enough of that. And now an AI generated picture. So starting off here, this is the framework components that I think of when I look at a general assessment of anybody who is acutely ill, be it in the hospital setting or outside the hospital setting. Uh, Most of these kind of A, B, C, D, E pathways are sort of designed for trauma specific care, but I still like to use it when I think of anybody who is acutely ill, altered, even if they're having maybe chest pain and a heart attack. Um, you need to, I want to consider what could cause harm and what needs to be addressed the very fast. Do I need to work on their airway? Are they breathing? Are they having, blood flow somewhere that's going from the body? Are they having peripheral circulation decrease because the medication they took or overdosed on clamps down peripheral circulation? So things to be considered. So A, B, C, D, E, this is not new. You guys do this all the time. But these are the things I want to kind of approach every one of these medications, every one of these drugs that I look at, we'll talk about, will more or less kind of follow that rhythm, not perfectly, but that's kind of the approach that I want to look at. So assessing things like from a neurostatus, are these person agitated? Are they hallucinating? These are classic signs and symptoms. Like, are they pinpoint pupils, are mitotic? Are they blown pupils? Are they dilated mydriasis? Or they look like they're on some pathomimetic, maybe cocaine? They got some money, I guess. Could be things like skin. Are they dry? Are they wet? These are the little cues and clues that we see. And again, you guys do this in a very quick amount of time because you not only take care of them in the field, you get them in and get them to definitive care. So moving on to the next thing. I think that's the next thing. We'll see. Yeah, that's the next thing. All right, I'll keep hitting the button. Toxidromes. So framework basically here, I have never loved toxidromes to this day. Toxidromes on questions when you do tests and stuff are somewhat useful, but they're also just kind of confusing. I take it for what it's worth, but I do think of these categories of medications and or substances, they're very broad actually, that we might interact with. I wouldn't get lost in it because I know that nothing presents. You're allowed to have multiple things happening and things don't have to follow the rule books or the textbooks, and they often don't. But thinking about classic things, opioids, we know that they're going to suppress our respiratory rate, respiratory drive. They have a central nervous system component, and they also can cause blood pressure to drop when they work on that mu receptor. They kind of this constriction of the pupils. You may have a normal skin finding, which that's not particularly helpful. And then mental status is one that is variable. So I don't put as much on that in terms of clear identification of what I might be looking at substance-wise, because you can see depressed. A lot of things are going to have sort of variable presentations. And the goal of these things are just tools to use, not necessarily a complete path. You have to go from 1A to then B. It's not like that because real life works differently. But you can see the different things you're going to obviously find. If somebody's on some pathomimetic, so cocaine, meth, you're going to see this. Like I said, patients tend to be agitated. They tend to be maybe a little bit aggressive. They tend to be all amped up. We don't typically have to, unless they have cardiovascular collapse, we don't typically have to hit them with a lot of fluids necessarily on the front end. They're going to be hypertensive. We're looking at controlling those type of things, which is, again, very different than the other medications that might fall into other categories like this, sedative hypnotics, things like Grandma or benzodiazepines that she's had for 20 years. So moving on, when I say supportive care, a lot of these things, a lot of these toxins, a lot of the ingestants that we see out in the field will have, some of them will have an antidote, right? Most of these things don't have an antidote. And most of these things are going to require some supportive care, even if there is a reversal agent like Narcan. You can give them Narcan, but most things aren't going to have a Narcan. Not that it's wrong to give Narcan. So area management, again, is more, it's like things you already know how already doing. We're looking at positioning the patient, making sure the airway is patent. Are they vomiting? Is there something I need to position them so they're not going to choke on their own sputum? They're going to aspirate. And that could be all the way up into, hey, do we need to take the airway? Do we need to intubate? Or if you need some other advanced airway, or maybe just a non-rebreather. Again, high flow versus nasal cannula versus other advanced airways, OPAs, etc. IV access, I always get amazed at how well you guys can do this. I'm a useless doctor when it comes to IV access. I can do IVs, but you guys do them so well in the back of a truck while somebody's trying to give you a hug while you're hooking up leads. But it's important. Like I said, we got to get in cases like that, supportive care, fluid resuscitation is going to be a big one for a lot of these things, especially when it comes down to patients that are hypotensive that may be fluid responsive. Continuous monitoring, so as best you can. Some people get hooked up to leads, some people get hooked up to their vital signs you're monitoring. Pulse oximetry, the respiratory rate, 12 lead if necessary. And then, like you said, looking at the level of consciousness, respiratory status. Antidote medications, there are some, Narcan, glucagon. Yeah, there's vasopressors, which is, encompasses other medications. Benzodiazepines also going to encompass other medications, Ativan, etc. And there's going to be specific agents that you're going to have and not have, which you guys know well. This is not an exhaustive list of what you can overdose on. It is a list of things that we see frequently, particularly in the ER, and not everything comes to the ER for sure, but the ER, we definitely see very common people come in for alcohol detox, or alcohol is a component of their overdose, or they have toxic or alcohol toxicity. Methamphetamine, unsurprisingly, is found in a lot of the UDSs, the drug screens that we do. Our drug screens don't cover every possible thing. There's things on this list that our drug screens don't test for. So a drug screen in itself for us is sort of a tool that we use, but we do see a lot of methamphetamines, and there are adulterants in people that may suffer from addictive behavior and harmful behavior don't necessarily go to pharmacists to get their stuff checked and cleared. The FDA doesn't necessarily track what is in it per se, and so you see some of these medications or some of these things as a co-ingestant or as an adulterant in other things. So MDMA, marijuana, we see a lot of people that come in nowadays. Marijuana is legal, more or less, in our area in Missouri, with some caveats. So we see a lot of people with things, particularly hyperemesis, is very common. It's really tough to talk somebody out of their marijuana, even when they're vomiting and having intractable nausea and vomiting. It's amazing. But so we do see actually quite a bit of that. The other drugs, designer drugs, some of these we don't test for, so it's hard to know exactly, but they are out there, and they are reported through other databases. Opioids, very frequently. Benzodiazepines, antidepressants, the most prescribed medication in the United States. SSRIs are. All the other things on the list. The one thing I didn't mention, which was noted today, and I didn't have a slide in it, but it's something to be aware of, is, and I'd butcher the name if I said it, but colloquially, you guys have probably heard of it. It's 7-O. It's a synthetic. It's more powerful. It's about 500% more powerful than the basic kratom, and the alkaloids is what they are, plant alkaloid extract. It's a synthetic version that bypasses the body's metabolism and has in-organ effects like euphoria, very opioid-like. It affects the opioid receptors, so it has an effect that is similar. And I did not put it on there, I apologize, but something to be aware of. There's not a test. We don't currently test for it, and it would not pop up. I had a patient about a month ago that was overdosed on it, and he was able to talk about his abuse history. So that's the reason why we knew. And he had other things going on as well. So starting off, everyone's favorite, alcohol. We see a lot of people that come into the emergency department, and seldom, I mean, sometimes there's accidental ingestions, but a lot of times people we see come in with a significant history of alcohol abuse. And some will come in for detox. Some of them come in because of an MBA. Some of them come in because they fell. Some of them come in from organic causes, and you guys take very good care of them. But it's commonly found in one of our screenings. If somebody comes in altered, I'm going to check their alcohol levels, their ETOH, ethyl alcohol levels, and then there's other alcohols you can test for as well. but particularly looking through the lens of ethanol, it's a rapidly absorbing, gets in the bloodstream, plus or minus. If you've been using it for a lot of years, your body can have a higher level of tolerance, and so you can tolerate more. If somebody's naive, it's going to take a lot less. Body mass does matter. Other things that affect it: food co-ingestion, the things that classically can affect the absorption of the alcohol itself. Um, when somebody comes in, and everybody's going to present differently, so these are somewhat idealized. All these are actually fairly idealized because, again, presentations don't always have to look the same. You're going to see slurred speech. You're going to see somebody may have disinhibited euphoric behavior. I'm thinking of a patient, for reasons and legal reasons I can't mention their name, but they're very frequently, and they exhibit all these behaviors. And uh, classically, a lot of people will come in with nausea and vomiting, especially they get to toxic levels of alcohol ingestion. We do, because we do check it. Alcohol, bonus points, has the kinetic elimination through the body is a little different. It generally what they call a zero order kinetics, and then at levels it can also be it can have a different kinetic elimination, so it's like 1 to 1. So generally we can predict when essentially how long somebody would be inebriated, more or less. So a lot of times treatment for this, if it's pure alcohol ingestion, we're going to go through that whole ABC list. We're going to check, basically make sure somebody is not unable to protect their airway, if they've not got a distracting injury. So many times, and as a resident and as a trainee, one of the things that we look at is people that have distracting injuries. And they classically would talk to us about two groups of people: people that are alcoholics and people that are elderly, that tend to hide things inadvertently in their physical examinations, because you'll not be able to get a good evaluation because they're inebriated, or they don't know how to articulate what's going on. So be aware, other things can happen besides the inebriation. Glucose. Checking a blood sugar, such a good thing. We give some other medications, thiamine as well, whenever people come in when they have acute alcohol ingestions or chronic alcohol ingestions, or they've detoxed and they're going day 4, 3, or 5 without alcohol. They're getting these significant withdrawal symptoms. So it can get pretty dangerous, as you guys have all seen and observed. So beyond the basic laboratory work, or say laboratory work, POC glucose, point of care glucose, so you guys would check with a finger stick. Supportive care, that's going to be, again, airway, breathing, circulation, plus maybe some IV hydration if they are they're needing it, or antiemetics. Opioids, all the buzz, all the rage. You know, I don't know what the TV commercials. I don't watch a lot of TV, but it seems like it's probably got something, a TV commercial about opioids. They certainly changed the prescription laws, and it's like a big focus politically anyway. They are safe medications when prescribed appropriately and supervised, but when they're not, people overdose on them. And so they affect mu receptors. It's just a fancy receptor that helps modulate pain in sort of a roundabout way. The other thing, though, is we have those receptors that live in other tissues, and so other parts of the body, not just the central nervous system, or parts of the central nervous system, I should also say, that control other functions besides pain modulation, including our ability to breathe. So oftentimes we've classically seen the patient that has had, our individuals had like a fentanyl overdose, which is 100 times more powerful than morphine. And that particular patient responds well to Narcan, but you can see they typically have that classic suppressed respirations, blown pupils, lethargy. They're going to be, depending on their stage of ingestion or how long they've been taking it, may have other things going on: nausea, vomiting. Histamine releases, that's sort of a rash you can get. Sometimes people do have those with morphine. You have it sometimes with fentanyl, sometimes methadone as well. Just a response, which can also be a semi-allergic reaction that can cause bronchospasms. All of these things are going to be difficult if somebody is not able to get treatment when you can't breathe, or you start losing your airway. Treatment, again, ABCs, Narcan. We're going to assess glucose, again, supportive care, IV hydration, plus or minus, airway. Are they going to need intubation? Are they not? Their Glasgow Coma Scale low? Are they vomiting? Is it going to be a concern for aspiration? So we're going to need to bag them. Are they just going to need a non-rebreather? Can we get them to where they're safe? And again, I remember the first time I was a student watching Narcan work years ago, and it was I think I got lucky or unlucky, I don't know which, but it was the classic response. This guy was had some chronic back pain and was unresponsive in the emergency department where I was a student at, and they gave it to him, and he became a holy terror. And so then he got intubated later, but it's effective and it works really well. Methamphetamine, there's no Narcan for meth. Um, so it's probably less. I mean, we see it frequently still. It's maybe a little less than it used to be, but it is still relatively inexpensive and accessible. So those are things that tend to lend themselves to drugs of abuse. There are other amphetamine medications and drugs, both prescribed and otherwise, that people do use. Stimulant medications are quite popular, and the Adderalls of the world are fairly ubiquitous and widespread in terms of being prescribed to patients. Um, and there are a host of designer amphetamines that are used for sort of more the hallucinogenic end of the spectrum as for response. And so with these kind of patients, I'm not necessarily looking at exactly which color of the rainbow that they are ingesting. I'm looking at how can I treat them and what I'm witnessing. But it is important to be aware of some of the ways that they may work. So medicines that block the reuptake of catecholamines, the presynaptic terminal, basically just means you get a lot of stimulation to your sympathetic nervous system. So you're going to be all flight, all fight. Sometimes you get some Spider-Man meth going on, and people go crazy. And we may have to sedate them to actually get them to be uh, safe for themselves and others. Um, the clinical symptoms are going to be variable, like most of these. You can see people that get agitated. You can see tachycardia. You can see hypertension. These are not things you won't see with others too. So I wouldn't anchor on any one particularly, but um, with the stimulants, it's going to be all generally up until crashing time, and then you may see a significant collapse in both cardiac and respiratory drives. Vital signs: checking ABCs, supportive care, hydration, and protection of the airway. Um, People that struggle with these sort of drugs of abuse tend to have poor nutrition, poor care in general. So when they come to us, a lot of times we are treating a lot of other comorbidities. A lot of times they're very dehydrated, and with that dehydration comes acute kidney injury and some end organ damage. In the field, like I said, uh, supporting them the best you can, and then bringing them in, recognizing it. Cocaine. We do test for cocaine. That's one of the UDS things that we test for. Um, I don't see cocaine a lot. I did have a patient recently who did have a history of cocaine abuse and had recent use. Um, and it is not as easily available, and it historically, because this is not 1985 anymore, it's maybe a little less in vogue, but it is more expensive, more designer, and there's other iterations, other versions of the cocaine that you may see. But classically, it is all sympathetic drive. It is ramping you up. It is things that are going to be seen when you have the fight or flight going hard and heavy, sweating, dry mouth, dilated pupils, tachycardia. Um, that is something that I've seen in patients multiple times. Again, clinically, does that matter necessarily when I'm assessing them in a preclinical setting? It may not, but it gives us some idea. There are some things that we can do to treat them, and there are some things that we should be aware of when we do treat. Cocaine, uh, many of these medications, but some of them have specific activity that works on receptors that are part of the sympathetic nervous system, and they affect our heart. And so cocaine induction or induces dysrhythmia as it can, and it has sort of a heart ischemia, so it blocks the blood flow. It can clamp down the coronary vasculature, the crown of vessels that come around our heart, mimicking significant chest pain, basically a heart attack symptoms. And you can start seeing those kind of uh, changes on an EKG even. So does like that's cardiovascular because of the CNS as well. And that's it's synergistic. It works together. ABCs, checking vitals is very important. One of the things, talk about calcium channel blockers they can use for overdoses and maybe some nitro depending for the vasospasms. Beta blockers are not something we want to classically give to somebody with cocaine-induced dysrhythmias or myopathy, because it can affect, when we block the beta, we get all alpha, and that stimulation can be deadly. All right, benzodiazepines. There's a criteria that we use in medicine. One of the criteria we use is called the Beers criteria, probably named after somebody named Beers. Basically what it says is patients over a certain age should be careful what kind of medicines rascally doctors give them, and they don't always pay attention to that. So generally over 75. When I see these overdoses clinically, and it can happen, there are people that abuse them, but what I see them clinically a lot of times are incidental overdoses or co-ingestions. When people have had, basically over that age of 65, people are more susceptible to these, the effects. They're a GABA receptor blocker, which is an inhibitory block or stimulation of GABA. I'm saying it backwards. They stimulate GABA, which blocks chloride channels. Essentially what it does is it slows things down. It kind of relaxes things. It breaks down with the feelings of anxiety, opposite of the sympathetic nervous system and sympathetic drive, relaxes things. Well, the problem with that is at high levels, or people that cannot metabolically process it, people who get a little bit older, people that have had some problems with the routes of clearance, typically folks that are older, can get toxic and have significant issues. I've had multiple patients that we have, patient over the age of 75 or 80 who's on a benzodiazepine for stable for many years for maybe their anxiety, so to speak, and they get up, take those medications to feel good at night or something, and then they are snowed, and either they can't breathe or they get up and they are unstable and they fall and break their hip. So they aren't benign. They have good places. They work well, but they are something we do see in terms of clinical causes of overdose. So some things you can look for. Again, these aren't super specific, mostly depressants. These are more of a depressant. Clinically, anything that inhibits stuff is going to depress your nervous system and your responses. So you're going to see somnolence, dizziness, slurred speech, confusion. Kind of, how is that different than somebody who maybe alcohol intoxication? It's going to look a lot like that potentially. And we do give people that have alcohol intoxication, particularly that are withdrawing from alcohol, we give them benzodiazepines to prevent seizures, and people that have seizures. So they have a good place in our armamentation, both pre-hospital and out of the hospital, but they can cause toxic ingestions for sure. Same kind of stuff for treatment and assessment. We're going to make sure they're safe. We're going to move them to a place that is safe and make sure their airway is intact. Check their vitals, check their glucose, and people may be having some responses because they're just hypoglycemic. Sometimes when we come in and people have stroke symptoms, we always want to check before I poke, prod, and test them for everything. They're just not overdosed on something that's causing their blood glucose to be low. So very important stuff. Next one up, the most prescribed medication in the United States by numbers are SSRIs, selective serotonin reuptake inhibitors. There's a whole bunch of flavors of these, and some more new, some are older, like the Prozacs of the world are older, and they have varying times, half-lives in the body. The benefit of some of the older ones, it's harder to overdose on them. I had a psychiatrist who had prescribed these in medical school, would talk about how many, like handfuls, and I'm sort of being tongue-in-cheek, you can take a lot of fluoxetine before you get to a level where you'd get to a toxic dose. It's such a long half-life. It doesn't absorb very quickly, but others medications do, and we do see them having sedative effects. We also classically, this is more of a board example, but I did have a patient in the last few months that after investigation and a UDS and a drug screen found out the patient did go into a serotonin syndrome. And this is one of these, not pathognomonic, but something that we see occasionally. Again, I don't know that I would want somebody to have to worry about a checklist. Does it have this? Does it have that? Is it serotonin syndrome or not? That's not particularly important, but it can happen. And these syndromes cause hallucination, diarrhea, nausea, vomiting. Classically odd things you do see. This guy came in with a pretty high fever. And the first thought was, this guy is sick and he's got an infection. He didn't have an infection. He was just overdosed on serotonergic or SSRIs. There's other medications that affect those receptors, and he just happened to be on multiple, and it precipitated this kind of thing. You'll get classic things with people that are again shivering, hyperreflexia, myoclonus. It's just the jerking motions. If you've seen it before, it's very rhythmic jerking motions. You can see it in your feet, you can see it in extremities. He had 105 was his temperature. He did respond okay. I think because he was altered, we went ahead and did a huge workup where that generally involves, all the things. But it turned out just an SSRI, serotonin syndrome. So can happen, and they're again so ubiquitous, so widespread. You can certainly see people having these overdoses. Things to be aware of when you see somebody who is in a home environment with maybe an accidental or intentional ingestion. Um, one last story about it. I had a patient just this week. I'm in the ICU. Came into us with sort of being found down unresponsive in a care facility, like a halfway house. And the only medication they found by them, one was a medicine called gabapentin or Neurontin, and the other one was Ambien. So not exactly a serotonin or SSRI, but these medications can have super sedative effects. All right, TCAs, tricyclic antidepressants, old meds, but we still see people on them. And there is some off-brand or off-label uses that you can see. Sometimes they can be used for refractory headaches, particularly migraines. I don't see them prescribed a ton for that, but it is an indication. They used to be used a lot. Amitriptyline, nortriptyline were popular medications, but they're pretty old and have a high side effect profile, which makes them interesting for overdoses and makes them poor for patients. But the people I typically see on these or come in with ingestions are either accidental ingestions, like they just, the kid that got into grandma's cabinet, or they've been stable on it for many, many, many years, and for some reason they took too many. They generally work different than an SSRI, but they do have the similar effects of suppressing the respiratory system. They suppress our nervous system, which most things that affect anxiety and depression do. So the classic finding for these patient types, you can see if they have high enough levels, and it doesn't matter the exact level clinically, but you'll see a QT prolongation. Now, there's a lot of medications that cause QT prolongation. I'm sure you guys have seen that. Every time you look at an EKG or study stuff with EKGs, a lot of medications can cause these. But this is a classic medication. I've seen it myself in the emergency department. The treatment for it is going to be airway support. Going to check those vitals. You can give benzos. You can do sodium bicarb. Sodium bicarbonate is the treatment we typically do use. And if they have a hypotension, low blood pressure, we may have to use vasopressors because they are a long-acting medicine. The big thing we'd not want them to do, we'd want to prevent somebody, there's a chance they can get into a deadly rhythm, particularly ventricular tachycardia. You can have this torsades de pointes picture, classically with tricyclic antidepressants. Over-the-counter medications, we check for these. We check for these because they are common. Salicylate, so Tylenol is not that, but acetaminophen. We see, it's easy to access. So when people go to self-harm or maybe even accidental overdoses, this is not something that somebody's trying to get high. Somebody just doesn't know either the effect or they are trying to self-harm. Tylenol is one that I don't know would be easy to determine in the field particularly, but it is something that you can clearly see if somebody comes in and they have a bunch of Tylenol that they've ingested or empty bottles of Tylenol. That would be something that you could consider. But the way it works is basically it kills your liver. In the first 24 hours, you're going to see patients. And again, this is not designed to be like, well, use this out in the field per se, but the idea, you're going to see somebody going in, it's like, they're going to be anorexic. They're not going to eat. They're going to be vomiting. They're going to be nauseated. They're going to have some malaise. They're going to go through this quiescent phase where they feel better for a couple of days, potentially. They might have a little bit of tenderness in that right upper quadrant because the liver is the primary, the hepatocyte, the functional units of the liver themselves break down the normal Tylenol. But when you've gotten so much in the system, and that varies depending, you say 4 4 grams, 24 hours. Some people say 3,200 as a safe dose is actually quite a bit higher than that. But once you exceeded that, which is just a bottle of pills would be significantly more than that, you can start seeing these toxic developments pretty quickly. And then after that period, initially, you're going to have some significant pain. Patient's going to be going through organ failure is essentially what you start seeing. So encephalopathic, they're going to be altered. They're not going to be producing urine. They're going to be maybe even icteric or jaundice because of the spilling of the liver enzymes and the bilirubin. So it's very important. Pre-hospital, I think most of it is still going to be treat and assess as stabilizing the patient and getting them into definitive care. Aspirin, we see these a lot. And again, it's a co-ingestant. It's something typically it's easy to get a hold of. The pathophysiology is acidic, so salicylic acid is what it is, or salicylate is the technically the unprotonated or the protonated version, I should say. But the body takes it in and it becomes acidic. It changes the pH pretty aggressively, so you have this. You can get this metabolic acidosis with a resulting respiratory alkalosis. Basically, you get this breathing hard, trying to get that to counter the acid that they've ingested as our body tries to process it. In kids, you can see it a little different than adults. Tinnitus is a classical. I don't know that I've ever seen this, and maybe somebody has. It is a board thing that people talk about, the ringing in the ears. But in kids, you don't see that as much. In adults, supposedly, you can. But you're going to be altered. You're going to have that hyperventilation, which you're breathing out significant amounts of CO2, trying to shift your acid-base chemistry. It's going to cause respiratory collapse, and that can cause cardiovascular collapse. So supporting the airway, checking the things that we normally do is very important. There are a few things where activated charcoal and those type of remedies are even in use anymore. If you get somebody within generally the first hour, we can go ahead and do some of these activated charcoal. After that, I don't think it's indicated technically, but we still do things, if poison control wants those things, depending. And then sodium bicarbonate, we're thinking about, buffering that acid. That's really what the charcoal is trying to do inside the stomach. We don't do in the ED, we don't do a gastric lavage they used to do back in the day where they would pump the stomachs. We don't do that anymore. Some folks that have done it for a long time have probably seen it. I haven't personally seen it, but last one here is our NSAIDs. Whoops, I went past it. Getting happy with that remote. Next to last. NSAIDs, again, is common. You see them all over. People take it. People don't know what it is. People overdose typically. Most of the time, it's probably a toxic. It takes a lot of ibuprofen to get there, but it can be done. I don't see this very often. I haven't seen too many that reported an NSAID ingestion. Some NSAID medication, non-steroidal anti-inflammatory medications, do have more potent effects. One of them, meloxicam, is more potent. Ketorolac, Toradol, naproxen is a little bit more potent. So it wouldn't take quite as much as your run-of-the-mill ibuprofen to cause that. Very similar kind of symptoms that most of these have. You're going to have this nausea, vomiting, abdominal pain. And you could eventually sort of get to the point where you become either emetic or metabolically compromised. You can get apnea and coma. And the treatment for this is going to be similar to the salicylates, although sometimes you may have to give them an IV pressor medications to help facilitate, maintain that MAP blood pressure. Moving quickly. All right, last one that I have here, and I've seen this fairly recently, and these do come up quite a bit. Benadryl, or really medicines like Benadryl, which are antihistamine medications. Benadryl is diphenhydramine. It works by modulating histamine responses. And I took some the other day, not too much though. So it has a sedative effect. And, I think we used to give it to my dog when he was getting ornery. No judgment. But a little bit. He never got too toxic. But so it can happen though. We can overdose. One of my attendings tells a story about a young lady who had um, a a toxic dose of Benadryl. She was like a 19-year-old, and she was in her bathroom when she was found against the door. Mom found her, and they didn't know exactly what was going on, and had these symptoms where she was hypothermic, she was hot, she was flushed skin, she dilated pupils, she was confused with delirium, and they just so happened to decide to like. I don't think they were going to for a look into her GI system, but they did look. She had like a one pinkish looking like vomit that came up, and lo and behold, she had taken a bunch of Benadryl. The treatment for this, there's a couple different things you can do from a pre-hospital standpoint. Obviously, going to support things, supportive care, hydration, breathing support, making sure somebody is stable as much as possible. We can also give them benzos, even ketamine in some cases. Um, and that's kind of the end of the main things that I had. Big thing, I think, with any of these toxidromes or toxic ingestions or overdoses, this is a big, broad overview. It's not really, my goal is to make sure you feel comfortable with a framework of how I would want to recognize and treat somebody. If there's an antidote, give it. If I do the things that you're already trained to do, as far as make sure somebody's going to aspirate on their fluids, and make sure somebody, if they're having symptoms like withdrawal seizures, you can give medications, benzodiazepines as needed. And then thinking about things that look, hey, look, if somebody's got one thing on board, they may have multiple other drugs and substances abuse going on. So just because it doesn't respond to Narcan does not mean that it's not something else. You know, uh, Everything is going to present a little bit different. There's no book presentation that I've seen to date, although it does help to have a framework. Um, your initial assessment is key. Looking at that stuff, that's when you think about the opportunity for intervention, the things that you guys do on a daily basis, which is amazing. And like I said, it facilitates what we do in the hospital so well. Is can I recognize what's going on and what actions can I take? So, and then the good old supportive care. That is the majority of what I had. Again, I apologize for my gravelly, disappearing voice. Um, I feel like I'm bleeding out I'm going to inhale some TXA here pretty soon and see if I can make my voice a little more calm or something. Thank you guys for the opportunity. We do appreciate everything you do, and we do enjoy coming to be part of this whenever we can. And always feel free to come up and talk to us in the department when you see us. And again, I know that there's some frowny faces sometimes, but you guys are awesome, and we really do appreciate everything y'all do. Any questions? Only easy questions, actually. Only easy questions, no hard questions. Or if there's no questions, because you don't want to hear me ramble or bleed out my throat.
As we're waiting on those questions to come in, Dr. Phillips is our last speaker for the day, so we will, if you don't have any questions, so we will be back here at 8 a.m. in the morning with Dr. Swinney. Yeah, he's coming back for some excited delirium. He's always got a great lecture first thing in the morning.
Something.
So
it'll be something.
It'll be fun.
Wheelchair.
Yeah. We're starting to get the thank yous, so we appreciate you coming in again, even with your raspy voice.
Thank you, guys.
Thanks. We will see you in the morning at 8. Jeff, you have anything?
Do not.
All right. And you're not very vocal this year.
I'm not.
Tomorrow.
Well, probably not. We'll see.